Adam here with the third installment of respiratory acidosis, and today we're going to discuss the pharmacology. The objectives. The objectives are as follows. At the end of this presentation, learners will be able to state the common classifications for medications to treat respiratory acidosis. You'll be able to describe the pharmacology of 3 different types of medications in relation to the pathophysiology of respiratory acidosis. You'll be able to discuss the nursing implications for adverse drug effects specific to these drugs when treating respiratory acidosis. And you'll be able to discuss as well as investigate new developments and potential treatments for respiratory acidosis. Stay tuned, because here we go. So if you're new to respiratory acidosis land, which I don't blame you for this being the first time to stop by, it's an imbalance. I've been beating on this for the past 3 videos, presentations of respiratory acidosis as an imbalance in our bodies because the failure of the breathing, which is diffusion, perfusion, and oxygenation, and an accumulation of carbon dioxide. CO2 goes up when our breathing goes down. It's the imbalance. Here we are at the pathophysiology of respiratory acidosis. Let's do a quick recap and see where we are. That first, respiratory acidosis is a progressive process. It starts very mild and can progress to worse. And I brought you again these 3 x-rays taken in sequence from A through C, showing the progressive, how when your lungs get worse, respiratory acidosis will get worse. Your body maintains CO2 in a well-controlled range by balancing this production and elimination. CO2 is produced through metabolism, and it is excreted in our bodies or eliminated through breathing. The role of pH regulation of CO2 happens through ventilation. If there's a breakdown in ventilation, either the diffusion, the perfusion, or the ventilation itself, then there will be then you're at risk for respiratory acidosis. When you hypoventilate, which means like a decrease in the way your respirations, your body does not produce more. It actually produces more than it can eliminate. So your CO2 builds up, or your body retains levels of CO2, which increases the amount of carbon dioxide in your body. So when you have CO2, it mixes with water that creates carbonic acid. Carbonic acid through the chemical reaction will split into hydrogen as well as bicarbonate. The hydrogen will increases the pH of your body system, and the bicarbonate is the buffer. However, when you have more CO2 in the body, that increases your hydrogen, increases faster than the bicarbonate can be produced, and your blood pH will increase, making the blood pH drop, or like I said, your blood becomes more acidic. Here's the meat of this discussion: the pharmacology of respiratory acidosis. There are several ways that you normally reverse or treat the causes that create respiratory acidosis. You don't wake up one day and say, oh, I'm feeling a little acidic. It doesn't work that way. You have respiratory acidosis because something's going on with your ventilation. That means there's something affecting the way you breathe. You treat the underlying issue with bronchodilators. You treat these issues with corticosteroids, with respiratory stimulants. Sometimes you're not breathing well because you're ODing, so you reverse the drug overdose and you provide oxygen therapy. These 5 points are the common drugs used to treat respiratory acidosis, and I'm going to break out 3 of these. We're going to talk about bronchodilators. We're going to talk about drug antagonists, and we're going to talk about oxygen therapy coming up in our presentation of pharmacology for respiratory acidosis. Naloxone. First drug we're going to talk about for respiratory acidosis. And you might say, Adam, why are we talking about a drug that has to do when we're talking about our lungs? Well, Think about what's been going on in the news lately. You hear about naloxone's used for overdosing, and why is that important for our lungs? So I'll give you a second to think about it. As this page turns, we'll start talking about it. Naloxone is an opiate antagonist, meaning that it will take the place of the opioid in the receptors that are in the brain, the neuroreceptors that are in the brain, because it's actually a very competitive antagonist at the mu, delta, and kappa opioid receptors. So in this picture, these are the opioids, and they're settling in the neuroreceptors, and that's when they settle in after you've used some sort of opiate type of drug. You get the effects of analgesia, euphoria, sedation, bradycardia, and respiratory depression. Respiratory depression, my friends, is what the respiratory acidosis is all about. Is your breathing decreases from having the receptors blocked from the sedation effect. That's when you become acidic because you don't have any more oxygen coming into your body. You're not able to release the CO2. When you can't release the CO2, your body exchanges it over to hydrogen. The hydrogen makes your blood more acidic. And remember, this is not, you're not able to maintain life when you get at such a low level. So what happens, you get a dose of naloxone, and then you have your opioids right here are removed, and the naloxone settles in, and that what that does is that allows your brain, it reverses the effects of the sedation and the euphoria, the bradycardia, and the respiratory distress. So basically, it's an alarm clock that's waking up your system. So even though that alarm clock rings, when it's administered IV, nasally, intermuscular, the duration of the action is dependent on the dose and route of the naloxone. And so even though it might be quicker IV, you might get longer effects from an IM, but it might take longer for the IM to actually get in your body. So pretty much use whatever you got. In addition to that, the duration of action of naloxone may be shorter than that of the opiate. So it's not uncommon to have to give multiple doses of naloxone because of the amount of the opioid that's in the body. If you want to reverse the opioid, it's not a once and done. It could be 3, 4, it could be 11 times that you might have to give this drug in order to keep reversing it, in order to keep waking these people up and keep those opiate receptors clean, allowing their systems to function. So just remember that, folks. It's just not a once and done process. It could be multiple times that you have to give this drug. Age considerations, not really. It's pretty much if somebody's losing consciousness from opiate overdose or found down, you can give the naloxone, and if they are under some sort of opioid influence, then it will reverse. You will see the effects. However, if they're not and they don't wake up, well, you've crossed off the opioids off the list. It's not the issue. Effective treatment, well, like I said, when the person comes around, when they start to wake up, when they start breathing again on their own, that's actually when you know that you have effective treatment. If you give naloxone and people don't wake up, well, apparently it's not a opioid overdose that we're looking at. The side effects of the drug are as follows: reversal of the overdose. All right, I say that, but really, you have pretty much like a rude awakening. You think about people are super overdosing, and then in like 2 minutes after getting this, they're pretty much being pulled out of that, and it can go back and forth. So you might have uh, irritability, you might have some vomiting, you might have some dizziness, weakness, nervousness, restlessness, like I said, irritability. It could be agitation, hyper or hypo blood pressure. You might pick up like some tachycardia as well as some encephalopathy, maybe even some seizures if you pull them out from like a big enough overdose. Looking at patient education, well, we could talk about like with the drug that they just got, like why they were given the naloxone. I guess see down here at the bottom it says save a life, and this actually shows you how to use naloxone. And if you click on the little movie there, you'll talk about how to actually administer naloxone. And there's a link at the bottom of Narcan.com, which will actually has a brochure that can show you like what to talk about with people after they've overdosed. So you just reverse that overdose. And what are you going to do next? Well, let's provide some oxygen. Why? Reverse the hypoxia. Have you used any of these methods that you see on this slide? Well, let's talk about them coming up next. Ever felt out of breath? Maybe you've had an allergic reaction or your COPD or asthma is inflamed. Just take a quick look over the picture on the right side. You're going to see all the parts of the respiratory system. And the reason why I put this up is to show like oxygen travels through all this. When there's a breakdown in one of these points, you're going to have a breakdown in your respiratory system, and that leads to respiratory acidosis. So from the last slide, the second part of reversing an overdose is then you provide oxygen to reverse the hypoxia. But in this case, you need oxygen to be delivered, and you can't if you're having a breakdown in the respiratory system. When you receive supplemental oxygen from oxygen therapy, you're just pretty much reducing or reversing the amount of hypoxia and the hypoxia-induced tissue damage and malfunction. I do want to take you on a quick journey, the journey of oxygen, just so we have like a really good idea how it works in our bodies. Simple mechanics from our muscles in our chest expanding and contracting help pull oxygen in and push carbon dioxide out. This is a system that continues as long as we breathe and live. But now let's take a look at how the system from the very top and how it gets to our cells. We breathe in, air is pulled in, it's warmed, it's moistened, and it's scrubbed by our upper airways, and it's heated. As the air travels down our trachea into the lungs, it's pulled into smaller and smaller tubules called the bronchioles until it reaches the alveoli, which is the tiniest air sacs, which is where the capillaries which surround the alveoli which carries blood, and will replenish with new oxygen as well as pull out the CO2. Oxygen is carried by hemoglobin in the red cells, and these help carry the oxygen to all different parts of our body. Oxygenated blood rushes from the capillaries into the lungs through larger and larger blood vessels until it returns to the left side of the heart and is pumped back throughout the body. Large and small arteries provide a network to deliver the oxygenated blood to the cells. At points, these arteries break and branch and become increasingly smaller, and that's where oxygen is actually fed into the individual cells. So when it finally gets to the cells, it's delivered to the mitochondria, or as they called it in my microbiology class, the energy station of the cell. And this is the process, and this is where the combustion process creates the energy, or ATP, in the cell, and that's where the exchange is. Oxygen comes in, carbon dioxide is released. The process is pretty much reversed as carbon dioxide travels out of your body through the vessels, through the veins. The hemoglobin returns the carbon dioxide to the heart and to the lungs. Carbon dioxide is released back out as we exhale. And like I said, the mechanical process continues all over again. The process of oxygenation is actually driven in the brainstem, and this is where it's receiving messages from chemoreceptors in the carotid bodies that are saying that are telling us that we need to breathe because of the hypoxic drive. So just giving a little bit of oxygen can actually change the way we breathe, and that can affect the way our cells produce energy and the way that we produce and rid our bodies of CO2. So now I think it's a pretty good time to talk about oxygen therapy. So oxygen supplementation acts to restore normal cellular activity at the mitochondrial level and reduce systemic acidosis. This can be achieved in multiple methods. First, non-invasive, or NIV, non-invasive ventilation, which is supplemental oxygen, BiPAP or bag mask, or using an ambu bag, as well as invasive, which is intubation or like a form of ECMO, the EECO2. Supplemental O2 is usually through like a nasal cannula or a simple face mask, and that's just to help keep our oxygen sats normal, as well as using the BiPAP. So when you still have that, you're still able to control your airway. That's when you can use a BiPAP as well as supplemental oxygen. The BiPAP uses pressure to help push oxygen into your lungs, which helps make that exchange of the O2 and CO2. And bag mask is pretty much as you're losing consciousness, or if people just need like an extra pump of oxygen, the ambu bag is attached to oxygen and it's placed over the face, and the bag is squeezed, delivering a breath of oxygen, like about probably every 6 seconds or so. So these are non-evasive, and this is a good way if people are able to maintain their airway, you can receive oxygen in this fashion. However, when times you're not able to maintain your airway because of an overdose or too much CO2 in your body, you may need to be intubated. Intubation is when you take an endotracheal tube, stick it into your trachea, and then a cuff is inflated and the tube is attached to a ventilator. The ventilator is adjusted, the depth and the rate, so the tidal volume, the amount of breath that you get, as well as how fast you breathe, can be adjusted, and that can be adjusted to an ABG, so you can deliver the amount of oxygen and to correct the acidosis as needed. Extracorporeal carbon dioxide removal, or EECO2R, is a newer technique for removing carbon dioxide through venovasus bypass without truly affecting oxygenation. So if you have somebody who has very stiff, non-compliant lungs or some kind of lung damage, you can put a simple dialysis port into their chest, and you can use this machine much like ECMO, and you can do like a where you just circulate the blood, and it can pull out the high levels of CO2. Though I've never seen this kind of technique performed, it's said that it is new and it is possibly a good way of removing CO2 from bodies. I'm gonna have to say with that there are really no age factors when giving oxygen. It's probably one of those drugs that you can give to somebody who's just born up to the very last breath that you take. People can get oxygen because we need oxygen to live. With that said, you can't get a preemie too much oxygen because that can turn into oxygen toxicity. And you can also give somebody who has horrible COPD too much oxygen, and that will take away their 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 hypoxic drive to breathe. So yes, there is monitoring that you have to do when you're giving oxygen. How do you tell if the drug is working? Well, quite simply, are they hypoxic? Are they acting hypoxic? Do they look blue? Are they acting in distress? What does their pulse ox say? What's their ABG say? So that kind of segues into our next point of like, what are the important assessments? Well, let's take a look at think about like what does hypoxia look like? Well, confusion, change of mental status, and it could also range from maybe like cyanosis around the lips, numbness and tingling, or poor capillary refill in the fingers and toes. Or it could be, like I said, like the pulse oximeter, which is a clip that's generally on the finger. It could be on the ear. It could also go on the forehead, but tells you an estimated amount of oxygen saturation that's in the blood. And with this, you're looking for normal levels, usually in the range 95 to 100%, maybe a 92. That could be under discussion, I guess. However, what's really important is if it's under 90% with a good waveform, then you're most likely in some going into some zone of hypoxemia, which is below the normal level of oxygen that's found should be in the blood. Another solid assessment for finding out if your blood has enough oxygen in it is the ABG. Remember ABGs? We discussed these past couple presentations, and I'm gonna give it one more plug. ABGs is an arterial blood gas, and in my past presentation, I talked about the ABCs of the ABGs. Quite, and this is like a pretty easy way to remember what ABGs do. They measure the acidity of the blood, which is your blood's pH. They also measure the bicarbonate, which is the base, which helps keep your blood from becoming too acidic, and it measures the carbon dioxide. And the carbon dioxide is what helps form hydrogen. So your ABCs, your acid, base, and carbon dioxide, and this gives you an idea. So when you take a draw an ABG, it gives you arterial blood, and it tells you if your blood's acidic, and it can also tell you what components are if your blood is balanced, and it can tell you how much oxygen and it can tell you how much oxygen is in your blood. And so it's also a very good way to seeing if you are hypoxic. You ever hear this song, Love is Like Oxygen? Well, that's because oxygen can be toxic. Major side effect of too much oxygen is oxygen toxicity. That's when you have too much oxygen in your system. This can be issues such as ocular effects, pulmonary toxicity, CNS toxicity, as well as other issues in your body. However, it is very real. It's an issue with very young, usually premature infants who are born who are at risk for this. Another side effect could be patients with COPD, where you could have carbon dioxide narcosis, and that's because you took away uh, the drive for them to breathe because it's their blood actually has too much oxygen saturation, and instead so they don't breathe off that hypoxic drive. And you see our little picture under the right, signs and symptoms of oxygen toxicity. If you can tell me who sang the song, Love is Like Oxygen, you get 3 extra points at the end of this presentation. Now, as ridiculous as it is, what are some important patient teachings? And one thing is to say, when you send people home with oxygen, you got to tell them not to smoke. Any of you have any patients with stage 1 or stage 2 pressure wounds on their elbows because these people with COPD sit at their kitchen table, leaning on their elbows, putting their supplemental oxygen on their forehead while they smoke their cigarettes? I've seen it, I bet you 6 or 8 times. And this is one of the major points that we need to tell our patients when they go home with oxygen, that it is flammable. They should not smoke around it, and because it can combust and create a very bad fire in their house. Other points that we can talk about is um, how to use the equipment at home. Also, how to ensure that you have enough oxygen at your house. Safety, such as not smoking, or being aware of like the oxygen tubing so you don't trip over it, as well as care of the equipment. So let me ask you this: what do you do when you're having a COPD exacerbation or asthma attack? How can you get your lungs to breathe any easier? You take a look at the slide. You have any questions? You have any thoughts? Let's talk about that now. So what are you doing when you're having an asthma attack, when you have COPD exacerbation, when you're having a hard time having that air exchange with CO2 and oxygen? Well, you relax those smooth muscles in the trachea and terminal bronchial tree. How do you do that, you may ask? Well, take a shot of albuterol. Albuterol is a selective beta-2 adrenergic agonist, meaning that it stimulates the B adrenergic receptors, and what happens that stimulates the production of AMP, which mediates numerous cellular responses. And the big one here is that smooth muscle relaxation and inhibiting the release of mediators from mast cells in the airways. So it's stopping that allergic response as it opens up the muscles, allowing the airway to pass air much easier. So overall, inhaled short-acting beta adrenergic agonists, such as albuterol here, are one of like the mainstay therapies for COPD exacerbation because of the rapid onset and the efficiency in producing the bronchodilation. These medications can be administered through a metered dose inhaler or an MDI or a nebulizer. The MDI does need a spacer, which helps use the uh, provide the drug in an efficient manner to the lungs. Here's a great picture of that MDI with a spacer. As she's taking her puff off the inhaler, when you hit that inhaler, it goes in the spacer, and then you're able to breathe, and it actually is able to uh, uh, forces you to breathe at a rate where you actually get all the medication. Typical doses for albuterol, generally 2.5 milligrams by nebulizer every 1 to 4 hours, or 4 to 8 puffs on the MDI. 1 to 4 hours is needed. You can increase the dose with the nebulizer, but it doesn't really have the effect, though, on the breathing outcomes. What's funny is that uh, MDIs are considered to be just as effective as nebulizers. However, people rely more on the nebulizers because it's better delivered to the body, and there's less chance that the person using it is going to mess up the dosage. From what the research was that I've been reading is that many people with COPD have difficulty using proper MDI techniques, especially in the setting of exacerbation. So if you just hook up your albuterol to a nebulizer, the nebulizer does all the work. All you do is breathe in and out the best you can. From what I understand with the age factors, there's really not a whole lot out there except that under 18 you do need some precautions with the combinations of other bronchodilators. With our geriatric population, you need to make sure that people don't have any cardiovascular complications, because this can side effect of albuterol is increased heart rate and blood pressure. If I was to ask you, how do you know when albuterol is working? What do you think you would say? Let me give you a second to think about that. Well, decreased shortness of breath, and you just might feel much better, hopefully much more calm, that your body's not oxygen starved. Common side effects of albuterol: nervousness, shaking, headache, nausea, vomiting, sometimes a cough, throat irritation. I did say increased heart rate and blood pressure, but that is not true, because this is a beta 2 receptor agonist. Uh, it only relaxes smooth muscles with little effect on the heart rate. As with respiratory acidosis, a good idea might be able to check your blood oxygen with a ABG if you're in the clinical setting. When checking your ABG, you'll be able to find out if your pH is dropping, if you have high CO2 levels, or if you're having body compensate with the bicarb. Also, you can also use a pulse ox to tell how your oxygen uh, levels are. But overall, you'll know that albuterol, your system's working because of the albuterol. Education is always key, especially when talking about how to use an inhaler, when using an MDI with a spacer, as well as or possibly a nebulizer. Discussing points of what it feels like to be having an asthma attack, as well as what happens in the body and any kind of side effects you may experience. To provide links to resources such as the website for useinhalers.com, as well as the instruction of metered dose inhalers that's included here in this slide. So we're going to take a look now at the any age-related issues, as well as the Beers criteria. Beers criteria was a list that was created by Dr. Beers, focused on medications for geriatric patients, to decrease any kind of harmful medications or medications that are inappropriate for the population. I believe this is pretty much based on through studies, but it's like a risk benefit sort of thought process. It was then pretty much expanded from geriatric populations into uh, inpatient, outpatient population as well. It's been updated through the years several times. So this list is dynamic in the sense, and uh, I would imagine will continually be updated and reviewed. There are other lists out there, such as the stop and start tools for older patients. However, this is just another tool that can be used in treating the geriatric population. So, in all, that this is not the end of the road for like education. It'll always continue to expand along with the other lists, and people need to continue to be updated and educated on what's proper for use with certain populations. The list takes in consideration absorption, metabolism, elimination, distribution of medications, and it's to help allow or doctors the the ability to prescribe medications in, from what I understand, an underrepresented population, the geriatrics. The three medicines that I discussed in my presentation, naloxone, oxygen, and albuterol, are not on this list, and from what I understand, can be used with geriatrics, even though I, I, I do know that naloxone is not fully studied over the age of 65. With that being said, I did want to share this with this medication that's out there that can be used for pain management of oxycodone and naloxone, the combination drug. And I thought this was kind of interesting because you do get like the long-term pain medication of oxycodone as well as the naloxone, and this has gone through several, like multiple tests, and it's been shown effective with chronic pain relief, but it helps with keeping GI mobility. I just thought that was interesting because putting these two drugs together seems like a bit of a paradox, yet it seems like it actually works well. And it's good to see that pharmaceutical companies are being innovators out there looking for different ways to treat pain management in our geriatric population. So here we are in new developments. Let's talk about the pioneers in pharmacology. We'll look at Dupuzent here. I think that's how you say it. Anyways, originally created to combat dermatitis. As you can see on the picture in the bottom right, you have the red, angry looking arm. And on the other side, you have an arm that's not looking so angry. But what happened was that it was found that since this injection uses IgG4 antibodies, this knocks down the systemic inflammation for dermatitis. Well, it was found that this also relieves moderate to severe asthma attacks. So I believe that this has something to do with that systemic inflammation. And even though it might reduce your dermatitis, it's also going to reduce inflammation that's in your lungs. So it's a win-win if you have both of these issues. So in October 2018, Dupuzent was licensed to be able to be given as a treatment or I guess a treatment for moderate to severe asthma. As long as you are 12 years or older, you can take this. Like I said, once a week, sub-Q, clean up your skin as well as your lungs. All right, the recap. Here we are. If I would have had this at the beginning, I would have saved 34 minutes of your life watching this presentation, but I appreciate it. So, respiratory acidosis is a decrease in the respiratory rate and volume, which is hypoventilation. Because this happens when you have impaired respiratory drive poor ventilation, poor perfusion, or poor diffusion. This happens with toxins, with diseases, with asthma, COPD, airway edema. You treat the cause and provide adequate ventilation. You can use naloxone to reverse opioid overdose. You can use albuterol to relax smooth muscles in the bronchioles, and you use oxygen therapy to reverse hypoxia. Something I do want to touch on is the new developments in pharmaceuticals. Just because it's made for one thing, there's other happenings that occur, and it can be used to treat issues that it wasn't intended for originally, but it does happen, like with the dupexenol as well as the naloxone, oxycodone medications, as well as use of the Beers criteria, which is helping us be mindful of our geriatric populations and decrease the amount of issues people have with too many medications or medications that don't mix well together. This was a great presentation. I found it quite long, but I do appreciate you stopping in. I hope this helps explain why we would use the medications that I discussed, the oxygen, albuterol, and naloxone, in treating respiratory acidosis, because respiratory acidosis is primarily caused by something else, and you have to treat that cause before you actually can get rid of the acidosis. And here it is, the most popular screen of them all. Thank you for stopping by. Any questions, please let me know. Thank you.